Next up is clinical integration. This is co-chaired by Eleanor Wilson and Al Ruenes. Al has 72 slides. He promised me 6 minutes because he won't give me the satisfaction of cutting them off.
That would kill me. So I'll just ask that you indulge me a little bit. As we were all kind of beginning this walk together in the fall, I had a personal walk with my brother through the mountains of northern Spain, where 3 of our 4 grandparents are from, and we followed that Camino, if you're familiar with it. And so I've used some of the slides in there because there's some congruence between the walk that we're all taking together and the walk that I shared with my brother. So our committee meets at 7 a.m. on the first Tuesday of every month, and we generally ask folks from around our healthcare community to come and present certain topics. And some of the highlights have been some things that are looking to cut down on readmissions, like the heart failure stratification program, reducing risk at home, like the fragility fracture initiative. One of the things we're most excited about now are having pharmacy students embedded in the primary care setting along with behavioral health specialists. This is for D.L. Smith. Every good talk should start with a dead man with a beard. The glasses, that's just bonus. The point here is that we should be more visionary than this guy. You don't know him because of some of his beliefs. This is John Erickson, a surgeon, a British surgeon, who in 1875 said, "The abdomen, chest, and brain will forever remain free of the intrusion of humane and wise surgeons." This kind of healthcare climate that we're in now requires us all to remain very visionary. Oviedo is the birthplace of my paternal grandmother, and that's where my brother and I started our trek. You've heard a lot about clinical integration. Every presenter before me has mentioned it. The way I look at it for Eleanor's committee and my committee, nice move, Beth. Well done. Our committee, I think, our intentions are to take what we already do fairly well as clinicians and just do it better and do it more efficiently. We need to continue to improve our communication, and without communication, transition of care would just kind of break down. This journey that we're taking together, like every journey, begins with those first few steps. This is a fellow that I ran into in his forge, and he was working on a piece of wrought iron, and he was showing me the best way to turn a handle for a draw he was creating. And I asked him why it was the best way, and he said, well, he'd been doing it that way for 30 years, and that's the way his grandfather taught him to do it. And that's the problem I think that we get into. We think that the way we've been doing things because it works is the best way to do it, and we need to kind of break from that mindset. We don't have to reinvent everything. We don't have to come up with protocols. They kind of already exist. I got to walk with people from all different countries, mostly Eastern Europe. It's a very popular thing for them to do, and you learn to be able to communicate without a common language, but a common language certainly makes your communication much more efficient. And we as a medical staff have to decide, what is that common language going to be? Is it going to be Tiger, text, fax, email? I don't know. Consults have to continue to be physician to physician in nature. That's how they're most efficient. That's how important salient clinical information gets passed most efficiently. From our committee, one of the highlights from this kind of nascent committee is that we asked radiology to set up this helpline, a quick and simple way for someone to call and find out which is the most appropriate study to ascertain the clinical information we're looking for, to cut down on unnecessary studies and wasteful studies. Transition of care just doesn't occur when the patient leaves the hospital and goes home. There's all kinds of transition of care. We're coordinating efforts with Ken Coburn and the Population Healthcare Management Strategic Planning Committee to kind of be able to step back and take a broader look at healthcare and kind of gain a better vision as to what's out there, not just the narrow path that we walk as subspecialists or specialists, but to kind of see how our care coordinates with everything else. Some of the immediate directives we have are exciting. Most recently, we're talking about PCP requested home visits from the visiting nurse service to assess patients, and that can cut down on accidents at home. We're looking to embed, like I said, pharmacy students in the primary care offices to go over patients' medications list and to make sure medications are being taken correctly. It's not just which medications you're taking, it's the schedule of medications that's often important as well. We can't always predict what lies around the bend, and as we journey this path together, if we keep our eyes open, we'll hopefully find some hints along the way. Some will be more obvious than others, but without a guidebook to kind of help us in this journey, this task may seem monumental. But with a team of 300 physicians, beginning with Alan Abramowitz and right now ending with Mary Zoller, I'm pretty certain that if we as a team remain united in our focus and in our goal, that we'll be able to reach that final destination together, keep ourselves pertinent, and then that final destination, that final product of what this will become should have a small piece of all of us in it. I like this quote. When we started this whole process, we kind of agreed as a group that doing nothing was something that we couldn't do. So if we're going to have regrets, let them be our own. Let them be the regrets from the mistakes we made, from the decisions we chose to follow.